If you're pregnant, the idea of being put under general anesthesia for an emergency C-section can feel terrifying. Maybe you've heard stories about epidurals not working or deliveries going so fast that there wasn't time for one. Now you're wondering what would happen if that happened to you. And when that fear goes unanswered, it can add a lot of anxiety as you get closer to delivery. Hey, I'm Dr. Dani Fisher. I'm a board-certified anesthesiologist with 22 years of experience specializing in labor and delivery anesthesia. And in this video, I'll walk you through the real risk of dying under general anesthesia, what actually causes general anesthesia in the pregnant population to be riskier, and what your anesthesia team does to keep you safe. So instead of spiraling over worst-case scenarios, you'll understand what the real risks are, and most importantly, you'll understand what's being done to keep you safe. Over my many years of practicing, I've overseen thousands of laboring patients, participated in thousands of C-sections, and my practice cares for some of the most complex obstetric patients in Texas. This video is for you if you're pregnant, you're worried about the possibility of an emergency C-section, and the words general anesthesia genuinely scare you. We're gonna break that down in just a minute, but before we dive in, be sure to hit the like button so I know that this video is helpful to you. And also, if you're preparing for a C-section and want a clear, straightforward breakdown of what to expect, I've put together a free C-section prep guide. It covers everything from anesthesia questions to recovery, and the link is in the description box below. Okay, let's talk about when general anesthesia actually happens during a C-section, because it's something that a lot of people do not fully understand. The vast majority of C-sections, both planned and emergency, are done with a spinal, an epidural, or a combined spinal epidural. That means you're awake, you're numb from the chest down, and you're very present for the birth of your baby. I covered exactly what that experience looks like in a previous video, so check that out if you want a full walkthrough. I'll leave it in the description box below. But there are situations where general anesthesia becomes necessary. The most common ones are true obstetric emergencies when the baby needs to be delivered immediately, and there simply just isn't time to place a spinal, or sometimes the patient has a spinal or an epidural that isn't providing adequate anesthesia, and we need to convert to a general anesthetic to keep them comfortable and safe during surgery. In those moments, your anesthesia team moves very quickly and with a very, very clear plan. The big thing I want you to understand is that general anesthesia for C-sections is used less often today than it was decades ago, but when it is used, your anesthesiologist has been trained extensively for this exact situation. I want to point out a really, really important point here. If you have a labor epidural in place, the likelihood of needing general anesthesia significantly drops, even in an emergency. Most of the time, we can dose your existing epidural quickly to get you to a surgical level of anesthesia without converting to a general anesthetic. I see this every time I'm working on labor and delivery. Emergency situations occurred, but because we had a well-functioning epidural in place, we were able to avoid a general anesthetic entirely. This is one of the reasons I always encourage epidural placement early with my patients, not because you necessarily need it for pain, but because having it in place gives us options if the situation changes quickly. Later in this video, I'm going to walk you through the specific tools and medications your anesthesia team uses that have dramatically changed the safety profile of general anesthesia and obstetrics, and some of them might actually surprise you. But first, let's talk about why general anesthesia carries more of a risk in a pregnant person than it does in the general population. There are two main reasons: a pregnant woman's airway and aspiration. So let's first talk about the airway. When we put somebody under general anesthesia, we place a breathing tube into the trachea. This tube is the way that the patient breathes anesthetic gas while they're asleep, but it also protects the lungs by preventing stomach contents from spilling into the lungs. This is called aspiration, and it's life-threatening. We'll talk about aspiration more in a second, but in most patients, placing the breathing tube is very straightforward. In pregnant patients, however, the airway is physiologically different and it's more challenging. During pregnancy, your body retains extra fluid, and that fluid causes swelling throughout your body, including in your throat and around the tissues in your airway. And that means practically that the airway can be narrower and harder to visualize than it would be in a non-pregnant person of the same size. So think of it like trying to thread a needle in normal light versus low light. The target is small and the conditions are less than ideal in a pregnant patient. This is what anesthesiologists call a difficult airway, and it's one of the primary reasons that general anesthesia in obstetrics is more complex. The second major risk is aspiration, and this one is less intuitive, so let me explain it clearly. When you're pregnant, your stomach empties more slowly than normal. Pregnancy hormones also relax the valve between your stomach and your esophagus, and then the growing uterus puts upward pressure on your stomach. And what all of that adds up to is a higher risk that the stomach contents could come up and spill into your lungs when you're being put under anesthesia. As I mentioned earlier, this is called aspiration, and it's dangerous because stomach contents have acid in them, and acid in the lungs can cause serious, life-threatening lung injury. This is something that every anesthesiologist thinks about and plans for every single time we administer general anesthesia to a pregnant patient. It's never, ever an afterthought. In just a few minutes, I'm going to explain the specific medications we give before general anesthesia that directly address the aspiration risk and how they've made this complication far less common than it used to be. But first, I want to talk about the following. On top of the baseline risk that comes from being pregnant, there are certain conditions that can make general anesthesia even more challenging. I want to walk through the most common ones so that you have a clear picture. The first one is obesity. In patients with obesity, the airway challenge I mentioned earlier is often compounded. There can be more soft tissue around the airway, reduced oxygen reserve in the lungs, and positioning during surgery is a little bit more complex. Now, none of these things make general anesthesia impossible, but they certainly require additional preparation and expertise. The second thing is preeclampsia. Preeclampsia is a condition that some patients develop that involves high blood pressure and in many cases, severe swelling of both the body and the airway. And this can make an already challenging airway even more difficult to manage. Patients with preeclampsia often receive medications that affect how their blood vessels and blood pressure respond to anesthesia, which adds another layer of complexity. Some patients also have a naturally narrower airway, a shorter neck, or limited jaw mobility, or any other anatomy that makes placing that breathing tube technically more difficult. And this is true regardless of pregnancy, but when it's combined with the challenges of pregnancy and a pregnancy airway, it's something we assess really carefully in our pre-anesthesia evaluation. The big thing I want you to understand is that none of these factors means that something will go wrong. It just means that your anesthesiologist needs to be more prepared, which we definitely are. Really quick, I just want to remind you that if you're preparing for a C-section and you want to understand your anesthesia questions, what questions to ask your team, what to expect before the surgery, just download my free C-section guide that is linked in the description box below. It's written specifically for patients in plain language, and it covers a lot of what we talk about on this channel. Okay, next I want to talk about what your anesthesia team does to keep you safe. All the things that I described above, your anesthesia team has trained for it extensively. First, we do a pre-airway anesthesia assessment, or even in an emergency, your anesthesiologist will assess your airway. We look at the size of the mouth opening, the shape of your jaw, the mobility of your neck, and several other specific features that help us predict how easy or difficult airway management might be. It's a quick glance, but it's structured and it's a really, really important clinical evaluation. If we anticipate a difficult airway, we prepare differently. We have backup plans before we even start. I also want to share with you that over the last several decades, we have developed lots and lots of technological advances that make managing a difficult airway, specifically in pregnancy, easier. One of those things is video laryngoscopy. One of them is called a Glidescope, one of them is called a McGrath. And what these video devices do is that instead of relying purely on direct visualization to place a breathing tube, these video laryngoscopes have tiny cameras on the blade that projects the airway onto a screen, and it gives us a better view of even challenging airways. I've seen this thousands of times in a patient that would have been really difficult to get that breathing tube in years past is very straightforward with this new technology. The McGrath and video laryngoscopes have genuinely changed the safety profile of airway management in obstetrics. Other technological advances include pulse oximetry and monitoring, because from the moment you get into the OR, you are continuously monitored. Your oxygen levels, your heart rate, your blood pressure, and breathing are all tracked in real time throughout the procedure. And if anything changes, we're able to see it immediately and respond. So a few minutes ago, we talked about aspiration and the risk of stomach contents entering the lungs. We address this directly with medication. Before general anesthesia, patients typically receive medications that neutralize stomach acid and reduce the volume of stomach contents, which significantly lowers the risk of aspiration. But the most important thing that keeps you safe during your general anesthetic is that your anesthesiologist has spent years and years in residency and years in clinical practice preparing exactly for these difficult situations. The difficult airway, avoiding aspiration, and managing the high-risk obstetric patient. We've handled these situations repeatedly, and we have a mental framework and a physical toolkit ready before we ever walk into the OR. In anesthesiology, we are specifically trained to think about all the things that can go wrong with every patient we have, and we prepare for the worst-case scenario every time because that preparation is what keeps patients safe. Finally, let's talk about the things that you can do to contribute to your own safety if you do end up needing a general anesthetic. It's super important to give your anesthesiologist complete and accurate information about you before surgery. There are a couple of things that are especially important to share. For example, your history of anesthesia. If you or any of your blood relatives have ever had a problem with anesthesia or a difficult time getting that breathing tube in, a reaction to medications, or a condition called malignant hyperthermia, tell us. This changes how we're going to prepare for your anesthetic. We would also want to know if a dentist or a previous doctor has ever mentioned that you have a small mouth opening, a receding jaw, or a short neck. It's also something to mention. While we are doing a physical exam, these features are already something we're addressing, but your history helps us to build a more complete picture. Your current medications and supplements are also something that you should tell us about because they affect how your body responds to anesthesia. Don't assume we already know, tell us everything. And finally, if you're feeling anxious, definitely tell us. Your anesthesiologist is not there just to manage medications. We're there to help you feel as safe and as informed as possible before you go to sleep. The pre-anesthesia conversation is one of the most important parts of the entire process, and the more we know about you, the better we can care for you. Coming up, I want to leave you with the single most important takeaway from this entire video, because understanding this one thing can genuinely shift how you feel about going into delivery. So here's the big thing to remember. General anesthesia definitely carries more risk in pregnant patients than in the general population. That is true. The airway changes, the aspiration risks are real, and certain conditions like obesity, preeclampsia add complexity. But the risks you've heard about, the serious life-threatening complications, they are all extraordinarily rare, in large part because of training that your anesthesiologist has had, technology, and preparation that goes into every general anesthetic your team administers. You're not walking into that OR alone. You have an anesthesiologist who has prepared for your specific risks and has the tools and the training to manage whatever comes up. Remember that if you want to feel even more prepared going into your C-section, you can download my C-section prep guide below. It covers all the questions that you might have, what to expect from the OR, what to watch for during delivery recovery, and all is written in plain language. And if this video helped you, definitely give me a thumbs up, subscribe to my channel, and leave your questions below because I do read all the comments and they will inform future videos. For now, stay calm, stay informed, and I will see you in the delivery room. Bye.